Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is nutritional care of HIV-infected children and counseling of children and adolescents living with HIV. And the speaker is Dr. Yashwant Gabhale. Dr. Yashwant Gabhale, sir, is the additional professor with the Department of Pediatrics and the Program Director of the Pediatric Center of Excellence at LTMGH and LTMMC, Sion, Mumbai. He is also the in charge of Nutrition Rehabilitation Research and Training Center. His special interest areas include pediatric nutrition, pediatric HIV, and pediatric asthma. We welcome you, sir, for today's session and request you to start the session.
Thank you, Shweta. So today's topic is very precise. I will be talking about the nutrition care because in lots of things also I have to talk about the counseling after that, especially the children and adolescents. So without any delay, I will like to start. Can I have the next slide? So the objective of the session is that we have to assess what is the nutritional status of the child, because whenever we see a child with HIV infection also, and many of the children are malnourished also. So complete nutrition assessment has to be done when the child follows at our center. Then we have to also identify their nutritional needs, and accordingly we have to also plan the diet for them. Counseling plays a very, very important role because we know from the status of the parents, their economic condition is also not so good. They are below poverty line and they also have limited sources of income, and food availability in the home is also we have to be concerned. So, and whenever they come to our center, we should have a child-friendly ART center, and we should focus on child-centered counseling. And counseling is not only to the caregivers, but to the adults also we give afterwards. And the ART which they are taking is a lifelong ART. It's not for short duration. So that is very, very important. And what is the disclosure, how to do disclosure also we'll be talking in this session. And what are the other counseling messages we give. And lastly, we'll be touching upon the counseling of the adolescents who are living with HIV. Next. So nutritional care of HIV-infected children. So I will be talking about this first. So all of you know that HIV with malnutrition is very, very important for us. There is a vicious cycle. You are aware that what is vicious cycle? It goes round and round. Already the child is having poor nutrition status. They have weight loss, muscle wasting is there. There is also lots of macro and micronutrient deficiencies happening in their body. And this all leads to the impaired immune system, and then in turn leads to the poor ability to fight the HIV because their CD4 count is also low, and therefore there is higher virus replication happening in their body, which in turn leads to the increased vulnerability to the infections and frequency and duration of the opportunity infections, and which can lead to the faster progression towards the AIDS condition, that is a final condition, and which in turn causes the increased nutrition needs, and there is also malnutrition happening. We call it that there is a atrophy of the microbiota at the intestinal level. So there is also malnutrition happening, and therefore there is also a decreased food intake. Many children have repeated oral thrust, the appetite is decreased. So this is a vicious cycle which is going on. So we have to break this vicious cycle somewhere. Next. So we have to completely assess their nutrition status. Next. So coming to the diet history is what the child is taking at house has to be taken into consideration. And what is the child's growth pattern? We are already provided the growth charts with our, we have the white cards are there. So in that we have to plot their growth pattern, especially the children who are between 6 months to 5 years of age. Then what are the caregiver practices and what is the family food security that we have to take into consideration, and any OI if the child is suffering, because all of you are aware, any opportunity infection child develops, it leads to the decrease in the weight, and the child will not gain weight for another 3-4 months. So that is a very crucial period. There we have to act very promptly for the child. Next. So these are the WHO standard weight for age charts are there. All of you are aware that the child should follow should not follow between less than third or less than 2 standard deviation, but it should follow that 0 is there. So that is a standard. Where the mean is there. So that mean you should be following the weight. This is a road to the health chart is there. So any child is debating this weight according to his age, it is a red flag for us, and we have to seriously act upon that issue. Next. So there we have separate charts for the boys and the girls up to the age of 5 years. Now this is a length or height for the age chart. Any child who is less than 2 years who cannot stand properly, we take the length, and any child who can stand properly, we take the height. So accordingly, we can plot it a length or height for age chart. Next. This is a weight for length or height chart is there between 0 to 5 years. So where we can classify the malnutrition, whether the child is in severe acute malnutrition, moderate acute malnutrition, or it's growing properly. Next. So this is the curves which we can see in the growth chart. The first one shows the child is growing well because the curve is going up and up. So this is a very good sign if the child is behaving in this pattern. The second one is a growth curve. You can see the initial there is a weight gain is there, and then there is flattening. So this is again alarming us why the child has any other infection, or if there is any problem why the child is not gaining weight. So this second one is a very important, and third one is a very alarming where the child has initially gained weight, then there is a flattening, and then again it is declining. So the third one is very alarming to us, and we require to have urgent clinical assessment and further intervention so that we should not prevent any higher mortality in these children. Next. So this is a pictorial taken. It can show the child who is first child is a stunted child. You can see the child's height is less, but overall it doesn't look malnourished. Second is a normal child, height is good and is looking well nourished. And the third one is a vested, the height is okay, but you can see the body mass is not there. Baggy pant appearance is there. You can see the bones are there. So this child is a vested child. So this is how we can classify whether it is stunted, normal, or vested child. Next. So when you talk about nutrition status between 0 to 14 years of age, we have to look for any signs of severe visible wasting, or if there is any edema present at in both the feet, or we can take the weight for the height chart, and if it is showing less than 3 standard deviation or mid upper arm circumference less than 115 millimeter in children between 6 months to 60 months, that is up to 5 years of age. So we can label them as severe malnutrition. And above 5 years, we always take the body mass index, and we have age appropriate charts are provided. So according to that, we can classify any child who is above 5 years as thin, severe thin, and accordingly we can act for that child. Any child who is between 5 to 9 years of age, 129 millimeters is taken as cutoff, and 160 millimeters is taken as cutoff between 10 to 14 years of age. If the child has reported weight loss or very low weight, or weight for the age is less than 3 standard deviation or underweight, or his weight for age is less than 2 standard deviation, or confirmed weight loss is there, that is more than 5% since the last visit, or there is a growth curve which is flattening on the growth chart, is a very poor weight gain is there in that child, and a child who is gaining weight, but the weight for the age is more than 2 standard deviation and gaining weight is appropriately, it's labeled as growing appropriately child. If the child has any underlying chronic lung disease or TB or persistent diarrhea or any other chronic opportunistic infections or malignancies there, it is labeled as conditions with increased nutrition needs. Because all of you are aware, any child who has any other comorbid, co-infection or any other OI is there, there is an increased demand of nutrition is there for that child over and above the normal nutrition requirement. Next. So this is a chart which depicts the total energy need of a HIV infected child. A child who is between age group of 6 to 11 months roughly requires 690 daily energy for their daily living. And if child is HIV infected and asymptomatic, then 10% additional is required, because since he's having HIV, 10% additional energy requirement will be there. So it will come to around 760 kilocalories. And if the child is having other symptoms, then 20% of the additional energy requirement will be there. So it will come to around 830. And if the child is severely malnourished with HIV infection, and once it's stabilized, the post-stabilization will require around 50 to 100% of total additional energy is required. So that will come up to 150 to 220 kilocalories per kg per day. So similarly, for each age group, like between 12 to 23 months, the chart is given that it will come to 900. If 10% for additional energy, it will come to 990. And if he's infected with poor weight gain and other symptoms, 20% additional will come to 1080. And if he's severely malnourished and HIV infection, so likely will require around 150 to 220 kilocalories over and above the normal. So these are the charts we can follow, and you can always refer to this chart whenever the child comes to your OPD for follow-up. Next. Now coming to the nutrition management, how we manage the child. So there is the child we can have who has a visible wasting and can have bilateral edema. In the slide you can see you have to press the foot, and the pressure has to be given for more than 5 to 6 seconds, and there you can see this pitting edema will be there. You can also see severely impaired growth if it is coming to less than 3 standard deviation. And whenever the child comes to us, we have to also evaluate for anemia. Like most of the children we see, if they are malnourished, they are bound to have 70 to 80%. We see the anemia is there because they have worm infestation, they don't take proper diet, so anemia is going to be there. And as all of you are aware, there is 40 to 50% chance of tuberculosis developing in HIV infected child. So we have to always see TB as one of the common OI we see in these children. Whenever the child is put on the drug, they normally will have nausea, vomiting, or they can sometimes have drug-induced hepatitis also, where they will again have poor appetite. So drug side effects also we have to evaluate. And treatment adherence, because once we start the treatment, we have to see that child or the caregiver gives that treatment to the child, and their adherence to more than 90% at each and every time. And sometimes we can also have treatment failure rates. So there also we have to evaluate. And very rarely we can see iris after starting the treatment. So these are the things we can evaluate whenever we see a child with acute malnutrition. Next. So this is that child. You can see that visible wasting is there. The body mass is also lost. You can see all the bones is there. Next. So this is a chart which explains what are the additional energy requirements we can give in this child. As already discussed, that asymptomatic child who is having adequate growth, but since he is having HIV, he will require 10% of the additional energy is there. So that is come to around 60 to 70 kilocalorie per day extra calories. So how we can provide? We can add 2 teaspoons of edible oil and 1 teaspoon of sugar, because this can increase because calorie density will be increased, and it can be given in the porridge form. And if it is poor weight gain and there is increased nutrition requirement, it will come to around 20 to 30% of the additional energy. So that will come roughly to around 120 to 150 kilocalories per day. So that will again, you can add like 2 teaspoons of edible oil or 1 to 2 teaspoons of sugar to the porridge, and this can you can make the energy dense accordingly. Next. So similarly, between 12 to 23 months, again, how to make energy dense? We can add 2 teaspoons of edible oil or 2 teaspoons of sugar to the porridge, or 1 medium banana can be added. Or if it is a poor weight gain with 20% to 30% extra additional energy required, we can add extra cup or 200 ml of milk with 1 teaspoon of sugar, and 2 big idlis can be given, or 2 chapatis with ghee or butter. Depending upon their affordability, we can advise. So whenever you are advising a diet, you have to take into consideration the social status of their family, what are the readily available food items are there. And so that we have to encourage, since we are fortunate that we are the center of excellence. We are having a dietitian, in-house dietitian, and whenever we have these malnourished children, we have special emphasis on their nutrition requirements. We have one-to-one sessions with our dietitians. She charts the diet as tailor-made diet is given to the child, to the family, and we have all the charts are available put up in our OPD, where we can explain which are the healthy food items are there, which are the junk foods, and which can be encouraged to your child. Next. So similarly, for 2 to 5 years also, they will require additional calories of 200 to 140 kilocalories if they are asymptomatic. If there is a poor weight gain and there is increased nutrition requirement, they will have 200 to 280 kilocalories per day. And if it is severely malnourished, 50 to 100% of the additional energy requirement will be there. So this can be sufficed with adding either extra cup of milk, sweetened curd will be given, or one extra roti can be added to there, or one vegetable serving, or one paratha can be given. So similarly, you have to tailor-made the diet as per their requirement. Next. Between 6 to 9 years, the same thing is there. So you have to always follow the charts, because if I explain to you right now, you will forget most of the things. So these charts has to be there in your OPD. If you don't have dietitian, then you have to become a dietitian. The doctor will have to become a dietitian. The counselor has to become a dietitian, and they have to tailor-made the diet for the child. Next. So this is for 10 to 14 years of age. There we can add extra one roti or lunch or dinner, depending on the feasibility, availability of the food items is there. Or one, if a child is non-veg eater, then one egg can be given, because egg has a good protein source, so that can be added to their diet. Next. So micronutrient supplement is also very, very important. Like vitamin A is very important, because as you are aware, if vitamin A is in a decreased quantity, there is higher proliferation of the virus, because vitamin A is always required for all stratified squamous epithelial cells, gut mucosa, it is required. So vitamin A supplements has to be given for each and every child every 6 months up to the age of 5 years of age. So between 6 to 12 months, we give around 1 lakh international units orally. Between 1 to 5 years, we give 2 lakhs international unit orally. And beyond 5 years of age, the vitamin E could be supplemented through the daily micronutrient supplements. And always we have to look for deworming of the children, because we have seen that 80 to 90% of the children are having worm infestation. Roundworms will be there, pinworms, threadworms will be there. So you have to identify that, because hygiene is also not there. Always see for there whether their nails are trimmed or not. The nail hygiene has to be looked for the caregivers, the child, how they that also we're talking afterwards, hand hygiene. So this all has to be taken into consideration, and albendazole can be given as 400 mg single dose every 6 months after the age of 1 year. And this can be continued to the caregivers also. And continue the cotramasol prophylaxis, which is as indicated, because we have seen the simple cotramasol can prevent the PCP and various other like pneumonia, community-acquired pneumonia or diarrhea can be also prevented, because it is a very good drug which keeps the concentration at a baseline, and therefore the many of the infection can be prevented. Any patient who has a recent history of diarrhea, we have to always give zinc at a dose of 20 mg or 2 mg per kg per dose for a period of total of 2 weeks. And encourage, we have to also encourage their regular play or age-appropriate activities at home, or whenever they come to the center, we have to advise to the parents and administer all routine childhood immunization which are there under the National Immunization Program. Plus also you can encourage, if the parents are affording the other vaccines, such as seasonal influenza vaccines can be given to them, chickenpox vaccine can be given to them. If the child is not so severely immunosuppressed, hepatitis A vaccines can be given to them. Next. So since we are fortunate that we are having a Nutrition Rehabilitation Research Training Center, that is NRRTC, and we are the nodal NRC center for city of Mumbai, we have developed our innovative medical nutrition therapy. We call it as MNT. Is nothing but a mixture of soybean oil, groundnut paste, sugar, skim milk powder, micronutrient powder, and the emulsifier. The 1 cup of the MNT gives around roughly 560 kilocalories and around 14.6 grams of proteins. So whenever child is malnourished, once the child is stabilized of the acute phase, and then the MNT we can introduce in the wards, and this MNT is given as per their weight. Suppose a child is 5 to 6 kg of age, so 1 MNT cup will be suffice for the whole day. And this it is an energy dense micronutrient mix paste is there, and it has a very good taste, and therefore no additional nutrition supplement required when the child is taking MNT. Over and above, if the child feels his appetite is good, then you can afford the home foods, and there is no refrigeration required for this our MNT, no cooking is required, and it has a shelf life of around 2 years. So this MNT has other micronutrient mix also, which is providing their daily recommended dietary allowance RDA to the child, which can be in the form of vitamin A, D, E, K, B1, B2, C, vitamin C, vitamin B6, B12, folic acid, niacin, pantothenic acid, and so on. So you can see a child, the pictorial description, picture presentation is there, that before the giving MNT, he was very thin, he was malnourished, but after giving the MNT, after 8 weeks of therapy, you can see that good weight gain is there, and is looking good also. Next. So nutrition counseling is also very, very important. So all the counselors who are there in the ART center listening to this talk, it is very, very important for them, because we also have our in-house counselors at our NLRTC plus at our PCOE also. So we always talk to them about whenever we see the child in the wards also, we further emphasize the need for the additional food. What are the dietary modification can be made to required for the mid increased needs are there, and what are the safe food practices which they can practice, and what is the safe food and water storage methods they can having at home, and how it can be modified, and what are the hygiene issues they can modify at house. We always discuss these issues. Next. So the 5 keys to safer food is always discussed as you have to keep clean everything, like right from your washing your hands, food preparation, your utensils. It has to be you have to keep everything is clean. Is whenever you go to toilet, also after coming to toilet, you have to wash your hands. Encourage all the family members, the food handlers are there, and you have to also protect the kitchen areas and food from insects, pests, and other animals. So that keeping clean of house environment is very, very important. Then we should have a separate raw and cooked foods at house, like use separate equipments and utensils such as knives or cutting boards or handling for raw foods. Store foods in covered containers to avoid contact with the raw and cooked foods. Then whatever you are cooking, it has to be cooked thoroughly, so that whatever impurities are there, whatever organisms and germs are there, they will be killed. So you have to cook the food thoroughly, especially the meat, poultry, eggs, fish, and seafood, because there is the contamination maximum happening. And bring foods like soups and stews to boiling point, and reheat the cooked food thoroughly and bring to the boil or heat point until too hot or too touch, and stay while reheating. So these are the technique you should follow. Next. And keep the food at safe temperature. Keeping the food at safe temperature is very, very important. Do not store the food too long even in a refrigerator. That should be also avoided. Frozen food should be avoided as far as possible. Do not thaw the frozen food at room temperature, and use the safe water and foods at safe. Like when you're cooking the food is also what water you're using is very, very important. Do not use the food beyond its expiry date. Use the pasteurized milk only. Wash the fruits and vegetables in safe water, especially if eaten raw, because there are chances also this thing we have seen, helminthic infections we have seen worm infestation. Therefore, whenever you are bringing the fruits or vegetables from the market, there has to be washed thoroughly and cooked properly. Next. So now coming to the what are the feeding recommendations we can give during the sickness. As you are aware that less than 6 months we are encouraging exclusive breastfeeding and breastfeeding only, nothing else beyond that, because most of the patients are on exclusive breastfeeding because they are given ART right from the beginning, and we have to encourage that. Between 6 to 12 months of age, we still encourage the breastfeeding. And then the weaning is also started. When weaning also semi-solid, then we can introduce solid. Semi-liquid, semi-solids, and then solids can be given, like from mass, roti or rice is there, or you can also use the fruits, pulps can be given right from that, like mashed boiled fried potatoes can be given. So up from 12 months to 2 years, we have to again consider breastfeeding. All of you are aware that we encourage breastfeeding as long as mother is comfortable. We should encourage the breastfeeding in the mother, and then age appropriately we can start weaning after 6 months. And this weaning has to be proper, and we have to encourage whatever home foods are given. Don't encourage any commercial foods, especially dabbas which are available in the market, because they are very costly. They cannot be sustained for longer time. So we always encourage the home available foods, and we accordingly counsel the parents. Next. So in sicknesses also we are recommending them that the child, even if the child is sick, the child should be given proper diet. Like in sickness, if the child has diarrhea less than 6 months, encourage breastfeeding maximum mother can do. And you have to always remember that whenever the child is small, between 6 to 12 months, you have to supervise the child's feeding. You have to wash your own hands and with the soap and water whenever you are feeding the child, and see to that the child completes the whatever serving is given to him. And between 12 months to 12 years also, you have to sit by the side of the child, help him to finish the serving, and you have to teach your child wash his hand if the child is more than 2 years old before touching any food items. And if the child has persistent diarrhea, what are the feeding recommendations are given? That you have to give more frequent and longer breastfeeds day and night. If the child is taking other milk, you have to replace that milk and increase breastfeeding, because other milk will cause further deterioration of the diarrhea, and replace the fermented milk products such as yogurt, or replace the half of the milk with nutrient-rich semi-solid food. Add cereals to the milk such as rice or wheat can be added. And for other foods, follow the feeding recommendations as per the child's age. We can follow that. Next. So while doing follow up these children, you have to always see what is the condition of the child, whether it's growing well or not. If it's growing well, then the follow up nutrition follow up can be done after 2 to 3 months, not so frequently. But the child is very sick and requires care, has a chronic increase in nutrition needs required, then child can be followed up as frequently as 2 to 4 weeks. And if child is not well, showing signs of growth of faltering also there, where you can require more frequent visits, that can be encouraged, and we have to counsel the parents appropriately as per the case requirement is there. Next. Now coming to the counseling part, especially of the children and adolescents linked with HIV and AIDS, which is a very, very important part of this topic. So the child and caregivers should be counseled for what are the challenges they face as they come to the center. And our center should be a child-friendly AIT center, and we should have a child-centric counseling approach for the children. And counseling the caregiver child should be done for what the treatment preparedness, including their adherence, and then the follow-up counseling. Next. So whenever we come to the counseling part, it is always said that counseling is a very, very important, because if you counsel the parents, the caregivers properly, your success of adherence to the treatment is highly likely to be increased in that family or that child or that caregiver. So what are the caregiver related challenges are there? Whether there is frequent sickness or mortality in the parents are there, or whether there is a frequent changes in the caregivers. We can see that is happening if the child is single or double orphan. Then what are the attitudes, beliefs, or habits of the caregiver? Because we have seen that sometimes they start the medication with us and then they go for other alternative medications. So that also we have to see. And we have to always say, like diabetes, hypertension, this is also chronic but treatable disease. And if you follow the treatment with the ART, simple ART, which is available free of cost to the government program, you are likely to have a good living life, and you can always show them the examples of the bigger children which are following at your center. We can have peer groups formed at your center. We can have peer group meetings. Since we are having a mitwa, that is adolescents, we are having a regular sessions of mitwa at our center. This has really encouraged the follow-up and it has increased their adherence to the treatment. So you have to also identify the child-related challenges, because all children are depend on their adults. Because if you want to give medication to a smaller child on time, it has to be given by the adult. So you have to see what are the problems are there. And children usually have a poor attention span, whatever you are telling to them. And it is a difficulty experienced by child because they don't communicate to us with whatever they are thinking in their mind. And poor physical growth of the child and delayed development milestone. These are the another things, areas we have to tackle. Because sometimes the children, they want to say something, but they cannot properly tell the counselor or the doctors. So there is always a communication gap is that we have to minimize. And what is the home environment related challenges there? Is there a higher chance of sickness? What are the parent status is there? Whether they have advanced disease? What are their economic background is there? Whether they are facing this discrimination stigma at their local level? This all has to be thought and to be addressed properly by the counselors. Next. So addressing challenges by supporting the child and the caregivers to their sensitive and caring counseling is always an art. Counseling, I always say it's an art. How you counsel, it depends on, because we have seen that some of the people are very good in counseling, and once the counseling is done by them, the caregiver, the parent, they understand much. So it is again, everyone has to make an effort that they should be a proper, there should be a good counselor, and counseling comes by repeated practicing. And whatever the modules are there, they are very good for the counselors. So they have to refer. So by tailoring the counseling as per child age, developmental status, so that the ability to understand what is the HIV disease and treatment, and is or social circumstances are there. You have to also adapt the counseling to the changing needs as the child grows older, like regarding the disclosure issues are there. And you have to also identify the caregiver and the backup for the secondary caregiver if there is a problem at the family, if there is a single orphan or double orphan is there. So we have to always identify as a backup for caregiver for the child. And by sensitively addressing the challenges of coping, adherence to the lifelong treatment, and the issues of disclosure, confidentiality, stigma, discrimination, because we have seen stigma and discrimination is always there at or some other point they are facing. So that has to be also addressed. Next. So creating a child-friendly ART center, it is what you have to achieve. So how can we achieve that? We have to counsel the caregivers to support the children. We have to provide a comfortable and friendly environment at the center for the children caregivers. Counseling children to cope with their infection and look after their healthy about their health is also important. Since our is a pediatric ART center, so we don't have much of the effort to do, because we know what is the child-led counseling there. But in the other centers where they are not used to the child means pediatric counseling, so they face the difficulties, because most of the center having too much of the adult load, and whenever they see a child, because they have a smaller number of the children falling at their ART center. So especially these centers are facing the problem, but you can always increase your counseling skill, and you can make your all other adult centers also are child-friendly ART centers, and child-centric approach has to be there, addressing the child needs. Next. So it is always, we should have a separate room when you are doing counseling to these children, because separate room is why, because you can focus one-to-one basis, you can address their issues are there, you can talk to the child, talk to the caregiver, what are the things are there, what is their understanding about the disease, and now what they have to do, and what is the treatment we are offering. We should also have small chairs so that it will make children more comfortable and they can be more friendly with us. We can keep some drawing papers at the counselor's table, crayons. So in between the child, if is not listening to you, can ask him that whatever you're thinking, please put on the paper. You can give some corner where the child can sit and draw the drawings and all that. You can provide them storybooks, games. When the child is waiting for the consultation, there should be always a wall display of paintings done by the CLHS, which usually we have it at our center. Child feels good. Oh, this painting is made by me last time, or this is another painting that some other child has made. So this has to be encouraged at the center. Blackboard or chalk should be placed at a child's level in a corner of the waiting area. If you have a big waiting area, it's good because many of the ART center doesn't have that much of space. But in space constraints also, we can try some of the methods so that it can feel a child-friendly ART center where the child can express their creativity, and it can also help in developing more rapport with the counselor, with the doctors, and the child doesn't feel that he has come to the hospital or to the ART center. And always child will be encouraged to come to the center. He will remember, oh, that counselor has given me some crayons to draw some drawings, and now he has put up that my drawing in his room. So these are the innovative things we can make. So beyond just providing the ART, just doing the routine counseling, we have to go beyond, and we have to have some our own creativity at our own center. Next. So now coming to the child-centered counseling. So you have to always develop a rapport with the child and caregiver whenever they are meeting for the first time, because first time rapport is very, very important. If you don't behave properly or don't you can explain them properly, they will think that why I'm coming to the center, they are not talking to me properly, they are just giving the medications. There is no communication by the doctor or the counselor, nothing is there. So they will not feel motivated to come again to your center. So to increase more follow-up, more adherence to the therapy, we should have developing the rapport. And we have to also focus on what are the child, and you have to tailor to the child's physical and psychological development. The treatment is there, and you have to always promote what are the child's potential or abilities are there, with talking to them and having various tools at your center to express their thoughts, like drawing is there or storytelling is there. You have to always build their self-esteem, and you have to always respect that what are the child's identity or emotions are there. And we have to always have a non-discrimination approach, and you always maintain the confidentiality of the information which they are sharing to us, and always involve the child and the child caregiver, whatever discussions are made when they come to the center. Next. So one of the important skill of counseling is the developing a rapport. So greeting the child, saying how, introducing yourself, this my name is so and so, what is your name, and by telling him how can I assist you, and you would also clear their doubts, misconceptions, whatever they're there with the diseases there, with you would always talk to the caregiver, and you have to also assure the child that all the information or the caregiver that you are sharing with us will not be shared to any other your family members or any other caregivers. And you should have a neutral play and art activities to build the therapeutic relationship and the spirit of the collaboration at your center. So these are the things which can help in developing a good rapport with the caregiver and the child. Next. So one of the important art to develop your counseling skill better is listening. Listen whatever the child or the caregiver is saying. Listen them properly. Don't interrupt in between. And after they finish whatever it is telling to them, then you express your thoughts. And with your knowledge about the HIV and the disease, you can help them, and you can ask them that these are the things which we can do for you now, and then they can follow the whatever treatment is told by you. Next. So recognizing and acknowledging their emotions is also very, very important. Like any suggestion or advice provided by the counselor, it needs to be predicted on such understanding and acknowledgement of the child's emotions has to be there. And this will help the children can feel and they are comfortable whenever they are talking to you. So these are the things which can be developed to improve your counseling skills. Next. So you should have an acceptance and non-judgment attitude. So whenever it means that being non-critical and not blaming the child, whatever the behavior may be, or providing the space for the children to examine and analyze their actions. Ultimately, the child takes their decisions or himself or herself. So whenever they are saying anything, you should not be judging. You should not do like this or that. Whatever they are saying, you can accept that, and then you can analyze, and then you can give your expert opinion, or you can counsel them appropriately. Next. So questioning and paraphrasing. So all inquiries should be embedded within the counseling process, that is with the use of the child-centric counseling skills. So we can have open and close-ended questions that can be used to get the information from the children, and however to best understand where to the children facilitate that allow them to tell their stories in ways that are descriptive, detailed, and non-threatening. A greater use of open-ended questions can be encouraged. So whenever they are paraphrasing, ensures that the child's narrative is summarized in ways that reflect and validate the children's experience, and the counselor has to understand the child's whatever feelings are there, and accordingly we can do the counseling. Next. So once you are counseling the child, the parent or caregiver is also very, very important, because here we are talking of the ART not for 1 month, 2 months, 3 months, but we are talking the ART for lifelong. So preparedness counseling is the one where you have to prepare the family that now this is a disease, and then what is the next step is adherence counseling, because we are starting the treatment, and once you start the treatment, next comes the follow-up, and with follow-up counseling comes. Next. So what is treatment preparedness and counseling? It includes educating and preparing the child and caregiver for a lifelong therapy, and it may require several sessions, right, from beginning 2 to 3 to 5 sessions. And you have to necessary to evaluate child's social environment, take the social environment of the family, identify who is the caregiver who can give this ART to the child, because since the ART once we start, it is a lifelong, and we have to also take consideration the confidence of the child and who is the caregiver. And the major difference between the preparedness counseling for adults and children is that since children are dependent on the caregivers for treatment, the counseling for children includes along with the caregivers. Next. So we have to first identify who is the primary caregiver who can give this medication to the child. Then what are the advantages and limitations of the ART has to be told to them. It is a lifelong ART therapy, and once you adhere to the therapy, that is more than 95% adherence has to be there. Even if you miss a single dose, your there is likely chances that your CD4 count, viral load will get affected. So that knowledge you have to provide to the pictorial chart. Any drug toxicity which will be there after you start the medication has to be explained to them. You can get nausea, vomiting, diarrhea. So that has to be explained. And you have to help them deal with the personal guilt and worry which they are having, and emotional support has to be provided to the family and the caregiver, and family needs help understanding the accident illness and in application in the family before the treatment can be initiated has to be provided. And you have to sensitize the caregiver about the disclosure of the HIV status information to the affected child. We can follow the age appropriate counseling and disclosure to the child once the child becomes older. Next. So there are 5 A's which we always talk when you do the treatment preparedness. The first A is assess, second is assist, third is advise, fourth is arrange, and fifth is agree. So you have to assess the child and caregiver knowledge about the HIV status, what is their understanding, what is the HIV disease. By and large, most of the parents, they are aware of the HIV disease, and we have to also assess what are the potential barriers to the adherence, and the social support system is there. So after that, you have to assist the child and caregivers once you develop a treatment plan, that they will adhere to this treatment plan. So to assist the family that they will adhere to the treatment plan and then advise how the ART works. It is a lifelong treatment is there. Give them example like tuberculosis, this like hypertension, diabetes. It's a lifelong treatment. Once they're taking medication, they are feeling good. Similarly, if you take the ART, you will also live for longer time, longer duration. Your social life, this thing is also improved because child attendance can be decreased if the child is frequently falling ill, is going to a school. So that can be improved. His attendance will be increased, and the child self-esteem will also be increased once he's not feeling low. So therefore, ART has to be taken regularly, and then you have to also arrange for the medical investigation and appropriate referrals if they are required, and you have to agree that child and caregiver both understand whatever has been told by you and they are agreed to the formula treatment of the ART and they will adhere 100% to the treatment lifelong. So these are the 5 A's which we should be always talking about: assess, assist, advise, arrange, and agree to the treatment. Next. So next is what, when, how, and who. Like explain what, like what medication I will be giving to a child, whether it is in the pill form, it is a syrup form, what is the color, what is the taste. So that I want to explain. And dose has to be repeated if the child vomits, because this is very, very common once you introduce the ART treatment. So you have to tell the caregiver that you have to again repeat the dose if the child vomits within 30 minutes after taking medication. Because if they don't repeat the dose and if it's frequently happening, this will decrease the drug levels and there are higher chances of drug resistance at initial stage. So specify when, whether the medicine should be given or taken, how frequently, once a day, twice a day, before food, after food, fixed timing, that also you have to ensure. And with you have to, since it's a child, you have to link the timing with the caregiver, whether the caregiver is going office or coming late in the night, so that you have to sort it out and provide the details on how, like medicine will be given or taken, the tablets can be how, if it is a sport tablet, it can be how into if it is not a sport tablet, breaking of the tablet is not allowed. And the remainder should be timed about 15 to 20 minutes before the time of the fixed medicine. So they should not mix, they should not miss their time. So they can always put an alarm or they can know if in the night 9 o'clock is the timing. So before 9 o'clock, they should put an alarm that at 8:40, so it will remind it that at 9 o'clock I have to take the medications. And identify who, like who will give the medication to the child in the family. And it is therefore very essential to identify the primary caregiver and always have a backup. Suppose the primary caregiver is not available, is ill. The second who's a backup is there, he should give the medication to the child on time. Next. So counseling the caregiver about the side effects of the ARV is also very, very important, because once you start a treatment and there are side effects there are highly chances that they will not adhere to the treatment and they will go to the alternative medication, they will go to some other therapy, and we will have lost the follow of that child or that family. So prepare the caregivers for the possibility of minor side effects or like nausea, headache, abdominal discomfort, diarrhea will be there. So what are things you can do? We can, if the vomiting is there, you can give ondansetron to them. If there is a pain in abdomen is there, you have to identify whether it is due to gastritis, then add antacid to the their regimen. Provide always IEC materials on the side effects if they are available, and counsel about the mild side effects. They should not defer the treatment. They should again report to the ART center, see a doctor's advice, and then decide for the treatment. So that has to be ensured. Next. So it is essential to achieve the total viral suppression. If they are added to the more than 95%, we have seen complete viral suppression is achieved. So it is essential to educate both the CLHS caregiver about the adherence to the ART treatment at each and every time and at subsequent visits. And also check the child's visit to center whether they are adhering to the medication by doing the pill count, and involve the caregivers or the whoever the child is there by asking some questions if there are any difficulties they are facing for the adherence, and that we can be sorted out. Because many times if child is school going, there is always a fluctuation in the timing of the taking the medication. That have to be sorted out, and you have to always assist them so that what is the right time they can take the medication. So you can use the interactive methods such as pill charts or storytelling with the children so that their adherence will be improved. And various CRT reminder tools can be also prepared, such as the calendar alarms or SMS reminders or refill boxes, and pill charts can be provided with them if there is adherence issue problem is there at your own level. Next. So either there can be child factors or caregiver factors will be there, which forms the common barriers for the adherence in CL-HIVs. So that you have to identify. So since the small children are there, they always depend on the adults for giving the medication. Children always have likes and dislikes over the medications. We know that some of the syrups are very bitter, and it is very difficult to give this bitter medication. So we always have to, like, they can add sugar to that medication and give to the child. So child may have emotional issues also there if because the child are very attached to their mothers. If there is a loss of mother is there in the family, then this emotional issues will be there. The child will not take ART, and therefore this all issues has to be sorted out. If the child is not taking ART, then we have to identify. So, then the second caregiver has to be motivated, and these issues can be sorted out. Then what are the caregivers related factors are there? They have limited knowledge and understanding about the treatment, so that has to be sorted out. If there are any misconceptions regarding treatment, that has to be done on one-to-one basis. Then what are the health beliefs or daily routine or nature of the timing of the job of the caregivers there? If they are going early in the morning, then you can timing the ART medicines. If there is nobody is available in the family, that early morning they can give the medicines, and when they come in the evening, the second dose can be given to the child. Then if there are any attitudes of the caregiver towards adherence issues, or if there are any repeated changes in the caregiver in the family, so especially it has happened when the child is double orphan, these issues can happen. There is a repeated change in the caregiver. One, the auntie is giving, then second, some of the. So that has to be sorted out at the counseling, one-to-one counseling level when you are talking to the caregivers. Next.
Kiran?
Yes, sir. Voice is
Sir has logged out, I think. Participants are requested to kindly bear with us. So we'll join shortly.
Hello, can you hear
Yes,
me?
sir. Yes, sir.
Yes, sir.
Sorry, there was an internet problem at our end. Sorry.
No problem, sir.
So at follow-up counseling, this is next slide, no? Can I go to previous slide?
Yes, sir.
Okay, next slide. Next slide, yeah. So what is adherence fatigue? As a clinician, we are aware that whenever a treatment is prescribed to a family, they will adhere for few months, a year. But after a certain years, 1 or 2 years, now there is a fatigue in taking the treatment at the prescribed time. And the amount of medication they are taking, you can imagine they are taking in between the tuberculosis medicines. Along with ART, they are also taking TB medicine. Some of the time they are also prescribed the core trimethoprophylaxis is there. They are taking calcium tablet, iron tablets. So roughly they are taking 20 tablets in a day sometimes. So a small child who is has dislike for the medicine and the color of the medicines. Imagine for giving this child a treatment is a really a tough job for the caregiver or parent. And imagine if the both parents are died, the child in the hands of the caregiver. If the caregiver is not that keen, so imagine what is happening to the child. So this adherence fatigue has to be focused very importantly by the counselors at each and every visit, especially if the child is single orphan, double orphan, because they face the maximum challenges. So symptoms of psychological distress in the form of anxiety, depression, and fears may be apparent and lead to the poor school performance. So we have also seen the poor school performance of the child is also because they are feeling low esteem, they are repeatedly ill, they are malnourished, they cannot focus in the school. So that all has to be tackled. So adherence fatigue related complaint needs to be taken very seriously. Next. Now, very important issue is disclosure. When, how, and how means what are the consequences of when you disclose? There are depend upon the caregiver's knowledge, attitude. So type of disclosure we can club into between age to 4 to 6 years of age, where we can do the initial coming to the ART center, he's curious why I'm going to the center. So you can always say that, okay, that these are the medications. Since you are taking this medication on regular, therefore you are feeling well. Therefore you have to need to come. This is a good medication that you should take daily. Partial disclosure is the one where we can do between 7 to 11 years of age, where the child is little bit mature. So where child is aware and parent has also chronic illness. So there we can do the partial disclosure. But full disclosure has to be done when the child is 12 years and above, where he has better understanding and he understand about the disease in a much better way. So there we can do the full disclosure. Next. So what are the things we can do in 3 to 6 years? That you are not well because you are taking this medication, you are feeling well. Therefore, you have to take this medicine, you have to come to the center. And if you want to play, and if you are not doing well, you will miss your school, or you will not go to the playground to play with your peers. Therefore, you need to take medicine. So this kind of messages can be given between 3 to 6 years of age, because they don't have much of the understanding about a disease. So we're not talking about a disease at the 3 to 6 years of age. So between 6 to 9 years, definitely you can say that a child has little understanding. You can say that you have germs in your body, and these germs is making you frequently sick, or we can tell that this medication water you're taking will kill your germs inside your body, and you will feel better. So these are the counseling you can do. And we are that Bum story and others booklets are there provided by the NACO that we can use for age appropriate counseling tools. That is things we can do whenever doing the disclosure. And the partial disclosure between 9 to 12 years, you can say that this germ in your body, this is reducing your body's ability to fight other infections, and it cannot remove from your body. Therefore, you have to take this medication on time regularly. So these are the things we can try between 9 to 12 years of age. And about 12 years, definitely you can go for the full disclosure. Next. So when you're preparing the parents or caregivers about the HIV disclosure, you have to understand the caregiver's fears and concerns, because sometimes they cannot accept that. They will tell doctor, don't disclose my child. He will have negative feeling towards me or towards our my family, and he will have negative impact. He may run away from the home and all that. So that you have to take into consideration and you have to counsel accordingly. That it is important to know that the level of the knowledge of the caregiver is there and provide the basic information to them about the HIV, how you can get this HIV and what are the treatment options are there, what are the symptoms are there, and why you need to take the treatment regularly so that you can control your disease in a better way. And they will then have a chance to ask the questions and clarify doubts. Once you provide the full knowledge about the HIV disease, then they can tell you that, doctor, these are the things are there. After providing knowledge, I am sure that they will not have any fear and they will accept that, okay, the HIV is there. Since I am having this disease, the child is also having disease. Now child should be also encouraged that he should get the knowledge about HIV disease, because he might indulge into the wrong practice afterwards. And if he come to know that he got the HIV from the parents, it will have negative impact towards the parents. So that will be prevented if you do a proper, appropriate age-based counseling. Next. So why the need of disclosure is there? That it is important to explain that the consequences can be keeping the information from the child away. Like sometimes the children, if you are not providing the information, and if they get the information from someone else, they will misinterpret the information, and the unprocessed thoughts or doubts or questions will they make them more anxious, fearful, and sometimes they can have negative impact. They can have suicidal tendencies. So that has to be tackled. Therefore, explaining the need for the disclosure is very, very important. And therefore, it is best to prepare the child and provide authentic information to avoid unnecessary traumatization. Who else, the counselor and doctor, who else can give them the better information? So we ourselves has to prepare the caregivers, counselor, and the child when you are doing the disclosure. Next. So addressing the parents and caregivers' fears and concerns. The parent may still have concerns and fears about the disclosure. It is common belief that the children not understand if told, as they are not mature. Every parent think that my child is not that mature enough. But after 12 years, depending on the maturity, we can always encourage the parents that this is the now right time so that I can disclose the disease to your child, so that child can be also prepared mentally to face the disease. Next. So how, when, and whom disclosure will be done is very, very important. So either a disclosure can be done by the counselor or the parent, and it depends on the circumstances of the comfort of the child. In case the parents carry out the disclosure process, the counselor can prepare them the right script to make disclosure. The counselor can guide the parent that this is way you can explain to the child on one-to-one basis. If you're not comfortable doing the disclosure counseling by the counselor, then you can counsel the child when your child is comfortable at your home, and accordingly and it is it will be done by the graded manner, not at a one time, not at a single go. So maybe 2 or 3 sessions will required to disclosure counseling. Next. So other counseling messages. So the counseling in terms of the nutrition, safe food handling, then counseling about the immunization practices, and counseling for the planning of the future of the CLHIV. So these are the things you have to always talk in details. Next. So counseling for adolescents living with HIV is very, very important, because adolescents are the population where we are facing much of the problem, because the treatment fatigue is also there in them. They have their own thoughts, and especially there are two groups we can think of. One is the vertically infected adolescent, that is parent to child transmission, and second is the horizontally infected adolescent. So vertically infected adolescent, it is likely to be advanced disease since they are vertically infected, and they're more likely to have OIs, and there is also growth and developmental which is usually affected, and they usually have a higher mortality rate, and disclosure of the HIV status can be a partial or none is in them. So they are likely to have experience of multiple HIV related losses in their family, since it's a vertical transfer. Either they are lost for both the parents or single parents, they were lost, and they have also experienced the stigma early in their life. It can be faced by them in the school or at the healthcare system. But in terms of horizontally infected adolescent, it is they are having a earlier stage of the HIV disease. So they are not in the advanced stage, and they are less likely that they are having more of the OIs. So OIs are less likely in them, and their growth and development is also not that much affected because they are not infected at the right from the birth onwards. So therefore, they have lower mortality. And if they are assessing HIV services, they are likely to know the status because they might have gone as a voluntary counseling testing service center, and where they are tested and they counsel that this is the disease they are having. So they are likely to have like familiar or social or clinical support system, and they might have also explained the stigma in the later part. So that has to be sorted out. Plus, they also have sexuality issues in the horizontally infected adolescents. Next. So it's a challenge for us, both in the adolescents and who are infected from the birth, and those who are horizontally infected. So the you have to make them strong, and you have to also explain what are the things are there in their life, so they can sometimes question the authorities, doctors, that why we are having this disease. And sometimes they also have a risk-taking behavior approach. They are also, we are likely to see that they have substance abuse, drug abuse is also there, and HIV-related stigma discrimination is also there. So that part has to be sorted on one-to-one basis. You have to take them into consideration. You have to counsel them properly. That okay, if you are having this disease, this is not the end of the life. Even if you are facing stigma discrimination, you have to overcome to that, and you have to have a safe practices when you are practicing. Even if you are indulging in those sexual practices, you have to have usually protection barrier has to be used. Next. So coming to the challenges, particularly for infected adolescents, is that they may experience poor physical growth, as I explained earlier. They have psychiatric and behavioral problems to begin with, and they are required to take daily medication of ART. They might have developed the fatigue syndrome of the medications. So, and sometimes they also question that why I'm having this disease, why not others are having this disease, why only me? So these are the things are there, and they are also having faced the HIV as well stigma discrimination. So they have to counsel properly because they have faced stigma during the school days or whenever they are assessing the healthcare system. The stigma discrimination has been faced by them. Next. In horizontally infected, also I have discussed earlier that they are also having this stigma discrimination problem, but it is not that much, and they can also have a you have to also know that what are the difficulty to reach out, discrimination, criminalization of drug use, sex work, or consensual sex between the males, and fear of arrest and abuse are there. So their risk taking here also you have to take into consideration. And delayed detection of the HIV due to the low index of suspicion is largely asymptomatic or adolescents, where the lack of adequate youth-friendly voluntary testing facilities are not there, or requirement of parallel consent for HIV testing is there before they reach the age of 18 years. It has to be done, and loss to follow-up is usually high in this population. So this is the population which we have to target, where they are having this horizontal infection is there, because these are the children or adolescents are there. The retention of these children into the program is very, very important for us. Therefore, they require a proper counseling or repeated counseling on one-to-one basis. Next. So we have to increase their environment, social environment, take into consideration, and difficult in accepting and learning to cope with their diagnosis and its impact on various aspects of their life. There is increased mental stress and risk of acquiring deviant and aggressive behavior by them. There is a higher chance of hindrance education and career-related challenges are there, and difficulty in coping with the relationship following the protected sexual practices, and the greater risk of unwanted pregnancies there. So these are the common challenges which are faced by them. Next. Now coming to the counseling ALHIV. So we have to counsel for the care and treatment. Like they have to understand what is the HIV, which is a lifelong priority they are taking, and therefore they have to adhere to the treatment at each and every time. And disclosure has to be done fully. And what are their healthy living practices they have to practice when they are having a risk-taking behavior. Nutrition also has to be taken consideration because they are in the adolescent phase, they are growing, and therefore their nutrition.
Ma'am, I think sir is disconnecting again. Shraddha ma'am? Participants are requested, please bear with us. Sir has an internet issue.
Participants are requested to please bear with us. Extremely sorry for the delay. We just have a few more slides left.
Hello.
Yes, sir. Yes.
Yeah.
Please.
Can you hear me?
Yes, sir. Please continue.
Yeah. Okay. So counseling, you have to due to the care for the care and treatment, like they should have the understanding of the what is the HIV disease. It's a lifelong ART we are giving to them, and treatment adherence, that is the treatment which we are prescribing. It has to be given lifelong as per the doctor's advice, and disclosure has to be done as per the age appropriate, and then full disclosure about 12 years of age. And what are the healthy livings they should be practicing, that also to be told to them. And nutrition very, very important, because it's an adolescent, they have a phase of growing, so that nutrition part also to be told to them. Then coming to sex and HIV, since they are growing up and changing behavior, they are likely to have indulge into the sexual practices. So we should have the counseling about what are the safe practices, sex practices are there, and also to prevent the unintended pregnancy, especially in the young adolescent girls. That has to be told to them. So life skills, they have to also learn the life skills, like what is the communication skills you should have, and how you should prepare their mindset, like handling the stigma and discrimination which is happening if at your workplace or the school or college level. They should be able to make their own decisions and plan their future. We have seen many of the young adolescents, if they are guided properly, they are uh, having a good education. Some of the children at our center, they are graduates, postgraduates, and they're doing well, and they're also doing the job at premier institutes. So these are the things we can do. Next, can I have next slide? So communicating with adults is very, very important. What are the do's and what are the avoid? So we should be always like when you communicate with adults, that be truthful about what you know and what you do not know, and be professional and technically competent when you're talking to them. Use the words and concepts that they can understand. Don't use too much of the medical languages or words, hi-fi words to them. Use pictures and flip charts whenever they are difficulty, if they don't understand what you are telling them. When you want to explain them, use flip charts or pictures to explain them. Treat them with the respect. Always, each and every person who is coming to the ART, we have to respect their dignity, and accordingly we have to talk to them. Treat all adults equally, and be understanding and supportive even if you do not approve their behavior. What are the things which will avoid? terms they will not understanding. So these are the things we should avoid. And talking down to them, shouting and getting angry or blaming them should be avoided. So when you, because the adolescent is the one population where they are think that they are knowing much more the things, and where they are also very aggressive. So there you have to always calm them, explain them what are the things in their better for better improvement of their life, that has to be taken into consideration, because many of the time they have a negativity towards life, and they have a low self-esteem. So you have to boost up their moral in such cases. Next. So again, by using the 5 A's, that is assess, advise, uh, agree, assist, and arrange. These things we can use when you are counseling the ALHIVs. So to assess the adolescent goals for their consultation, what is their physical, mental status there, whether they are sexually active or not active. If it is a young woman, then you have to assess for whether there is she is pregnant or not pregnant. Any other risk-taking behaviors is there in their which can have the HIV transmission, that you have to assess. Then what are the adolescent knowledge and beliefs is there, and support the structures who knows about their HIV status, that has to be assessed when you are doing the counseling of the adolescent. Next. After assess comes the advice. So using the plain and neutral, non-judgmental attitude and language, you have to correct any inaccurate knowledge and fill in the gaps of the adolescent's understanding on being young and living with HIV. Their sexual activity is, we have to always tell them that you have to use the barrier contraception, like use of condoms or contraception aspects can be used. Discuss the couple counseling and the benefits of disclosing HIV to the chosen people, and if on peer support or any other ALHIV is there. And lastly, also we have to advise for the adherence issues, and whatever treatment they are advised has to be continued lifelong. Next. Next comes agree. Advise for the you have to whatever the plan has been developed for the treatment of this adolescent. You have to discuss that plan, and the simplest possible thing is that you have to build up the confidence in them, and you have to make them to adopt this adherent to treatment plan, and take the adolescent developmental phase into consideration by using the Tanner scale, and when you prescribe the ART, so that the whatever treatment has been advised to them, they will adhere to the 95, more than 95%, and will follow up accordingly, so that we don't have loss to follow up of this adolescent population. Next. Then you have to make agree that to whom they will choose or disclose their HIV status, on how and when they wish to disclose their status, and support they may need, and then want a treatment plan that has been developed by them. They have to agree that this treatment they will take properly, and what are the adolescent priorities are there, that is also taken into consideration when you're discussing this plan. Next. I have to always assist, we provide a written or pictorial summary of the plan, provide referral to the adolescents, friendly healthcare workers and services, provide link to the support services, provide treatment and other medications, also provide condoms and contraception if required, if they are indulging into sexual practices, provide skills and tools to assist with the self-management and adherence to the treatment, and if help the patient to predict the possible barriers to the implementing the treatment plan, assist with the ALHIVs with the physical, mental, and social health well-being, and assist by strengthening the links with the friend, family, peer support groups, and the community services. Next. And finally, arrange for the next appropriate date, reinforce the importance of attending the ART centers, and for referral for the group counseling sessions or reliable support group. So these are the things we can arrange to them whenever the adolescent ALHs are visiting at your center. So these are the 5 A's where you can, if you use properly, you can have better follow up these adolescents and they will have a positive response towards their life, and they will add to the treatment more than 95% each and every time. Next. Disclosure in ALHIV, last part. So disclosure is a thing which can be done where you do encourage the adolescent to take more responsibility and participate in their own care, and it also improve their retention in the care services. So adolescents need ongoing support of disclosure for their own status and also the parental status to them. So it is important to ensure that the adolescent is ready to the process of disclosure, because it's a age where they say that whatever has been told to me, I understand a better way, and I can also assess various things about the diseases. So you have to always tell them that whatever knowledge you will get from the other sources will be half, and whatever we are providing the scientific knowledge. So always encourage the proper disclosure in these ALHIVs and manage the barriers to the disclosure. And then staff should be accessible and open to the answer for their whatever queries are there, because they will have thousands of queries in their mind. So each and every queries, if you are able to answer, you can satisfy them, so that they can also build up the confidence in your center and your counseling later on. Next. So this is all about my sessions, and I think next RDLS session is there on 23rd of March. That will be explained to you. That is on introduction to OIs and HIVs.
Thank you so much, sir.
I apologize for
no issues, sir. No issues. It happens. It's a technical glitch. No issues, sir. Thank you so much. Thank you to all the participants for patient listening. Are there any questions? Please feel free to unmute your mic. So I don't think there are any questions. Thank you so much, sir, for facilitating this session.
Thank you. Thank you, Sweta.
Thank you, sir. Kiran, sir, can we quickly run the feedback? Yeah, the feedback poll is now visible on your screen. All the participants are requested to please fill in the feedback poll. There are 4 questions. Please answer all 4 of them. Kiran, sir, we can end the e-poll. Thank you. Once again, thank you to all the participants. The next session will be on 23rd of March, and the topic is Introduction to OIs and HIV and OI CNS. For that chapter, for that session, you can refer to chapter number 4.1 and 4.2 of the National Guidelines for HIV Care and Treatment. We'll conclude the session now. Thank you.